Thank you very much for attending this session, and I'd like to thank Accuray and the organizers for giving us a chance to share with you our results related to what we term TMI, or total marrow irradiation, which is a more targeted form of TBI in our patients with bone marrow transplantation. I have no disclosures. I'd like to just start by thanking all the people who are involved in the effort at City of Hope. It's a large team in radiation oncology and bone marrow transplant, including our radiation oncologist, our physicist headed by Tim Schultheis. An Lu, who's sitting right here, has done a lion's share of the physics work. We have a large bone marrow transplant team headed by Steve Foreman, and the people whose names are underlined are the principal investigators of the clinical trials I'll update you on. I'd like to just go through the rationale of why we use TomoTherapy to deliver TMI, then give a brief overview of the procedure that we utilize, and then go through 3 clinical trials that are representative of our clinical experience. One of the reasons we were very interested in this approach is that City of Hope does have a very active bone marrow transplant program, one of the largest programs in the United States. Over 600 transplants per year currently, established in 1976. And also very important is our bone marrow transplanters are committed to using total body irradiation as part of the conditioning regimen for our patients undergoing bone marrow transplant. We perform about 120 to sometimes 200 TBIs per year. You see a picture on the left side of the annual reunion. Hundreds of people come back to City of Hope to celebrate a successful bone marrow transplant. And about 1/3 of those patients have had radiation therapy as part of their conditioning regimen. We feel that TBI remains an important part of the regimen because of its anti-leukemic effects, but also because of its immunosuppressive effects for patients undergoing allogeneic bone marrow transplant. In fact, randomized trials suggest that TBI-containing regimens are superior to non-TBI containing regimens. But TBI has its challenges. It irradiates the entire body with the same dose of treatment, and therefore it irritates those normal organs, causing side effects. So patients who are older, especially those over 55, aren't allowed to go through this type of conditioning regimen. Frail patients are also excluded from this, and it's difficult to dose escalate TBI in an attempt to improve outcomes. This is an example of an attempt to dose escalate on standard TBI performed by the Seattle group. It's a randomized phase 2 trial randomizing patients with AML in first remission between 12 gray plus Cytoxan and 15.75 gray plus Cytoxan. And this shows that there was a reduction in the remission rates, but you can see no change in survival because of treatment-related mortalities related to the higher TBI dose. So it appears that TBI does have anti-tumor benefit. Increasing dose will potentially improve those anti-tumor effects, but toxicities limit dose escalation. So what we needed was a more targeted form of TBI, or TMI, to reduce toxicities, to offer radiation to a broader spectrum of patients unable to tolerate standard TBI regimens, such as the population that I've gone through already, especially those with very aggressive leukemias, those that are not eligible for standard TBI-containing regimens. And it would give us the opportunity to dose escalate to potentially improve outcomes without increasing toxicities. TomoTherapy was the technology that we utilized to implement total marrow irradiation. We were early adopters, I should say. First unit installed in October 2004, second one in June of 2006. We felt TomoTherapy was the solution for us because we wanted to select differentiating technology. We wanted to be first adopters of that technology, and we were looking for a partner that was an excellent industry collaborator. Ultimately, we wanted to grow our program and to complement the City of Hope's strengths, in this case, bone marrow transplant. And at the time, TomoTherapy was clearly the only technology suited to this particular application. Our first efforts were preclinical dosimetric comparisons. We took a data set from a 20-year-old with AML. We performed a TBI dose plan. For our institution, TBI is usually 12 gray at 1.2 gray TID with 50% lung transmission blocks, underlying chest wall boosted with electrons. And we performed on the same CT data set TMI plans from 12 to 20 gray. The target structure in this case was skeletal bone. This is a bar graph of the median or D50 organ doses. And as you would expect in red, the TBI organ doses are close to 12 gray, except for the lung, which is a median dose of about 9 gray. We could escalate, as you can see, our TMI plans even to 20 gray without reaching standard TBI organ doses. This is a DVH from that example. This is a TMI at 12 gray. As you would expect, going up to 20 gray, the lung DVH shifts to the left. And this is the TBI 12 gray lung DVH. And we felt potentially in our clinical trials we could escalate up to 20 gray before the lung DVHs became similar and the pneumonitis risks would become similar. Just a brief few slides on our methodology. We simulate the patient supine. We immobilize through a full body back lock from the shoulders to the feet, thermoplastic head mask, and we use a special molded cushion to keep the neck and shoulders reproducible. We perform 3 scans, CT scans, 1 in quiet breathing, 1 in full inspiration, and 1 in full expiration. We usually put a 5mm margin around our target areas, except areas such as the shoulder and the neck, which are sometimes difficult to get reproducible positioning. Sometimes we put a little bit more margin there. The jaw size is 5 cm. You can see the pitch and modulation factor. This is a picture of the immobilization setup. And as we have published, we treat the lower extremities at our institution using APPA standard fields on a C-arm Linac. So let me now go through the clinical trials. I'll just choose 3 trials as an examples of what we are doing. We treated our first patient in June of 2005. To date, we've treated over 220 patients. These have mostly all been on clinical trials. 5 clinical trials have been completed. 2 are ongoing, 2 are planned. When we look back on the experience, we walk through sort of 3 phases in our clinical studies. 1, TMI without concomitant chemotherapy. The next phase was TMI, or more specifically TMLI. These were trials that combined TMI with total lymphoid irradiation. We refer to it as TMLI, with a reduced intensity chemotherapy regimen. And then our recent efforts are TMLI with standard or higher intensity chemotherapy regimens. So this is the first effort, TMI without concurrent chemotherapy. The concept was developed in 2003 in patients with multiple myeloma. At that time, autologous tandem transplants were a very hot topic in the myeloma field. And the trial was first high-dose Melphalan, followed later by standard dose TMI, 12 gray. It would allow us to evaluate TMI without concurrent chemotherapy as our initial effort. It would allow us to establish the baseline toxicities for TMI. And this was a phase 1 trial, so we started at 10 gray actually, and then escalated the TMI dose to determine on a phase 1 trial setting the maximum tolerated dose of TMI without chemotherapy. Patients entered on the trial were those with stage 1 to 3 multiple myeloma, mostly stage 3. They had to be responding to their initial therapies with less than 10% involvement of bone marrow. This is the study schema. The first part was a high-dose Melphalan, 200, followed by half the stem cells reinfused. And then about 6 weeks later, a minimum of 6 weeks later, the TMI was done. Again, this is the phase 1 portion, escalated at 2 gray increments. From 10 gray, we anticipated getting up towards 20 gray, delivered in BID fractionation, 6 hours between fractions, followed by stem cell infusion, and then maintenance decadron and thalidomide. The phase 1 trial has been published. The PI is Dr. Samlo, the reference is there. 22 patients were reported on, escalated from 10 to 18 gray. Median age, you can see there, 53, mostly stage 3, not heavily pretreated, no previous radiation therapy in this population. This is a table showing the NCI grade 3 toxicities. This was the toxicity scale used to define the MTD. You can see from 10 to 14 gray, very few grade 3 toxicities. At 16 gray, you saw there are 2 instances of nausea, but it was felt secondary to poor compliance of their anti-emetic regimen, so were allowed to dose escalate. And at 18 gray, we hit MTD on this trial. The first patient had pneumonitis that responded quickly to steroids, and the second patient had an episode of hypotension that responded to pressors, not felt secondary to the radiation, but felt secondary to engraftment syndrome. So in this initial effort, this was, I believe, the first effort done, we showed that using TomoTherapy, we could deliver TMI. There was a reduction in organ doses per plan. We felt the acute toxicities were consistent with those reduced organ doses in that we saw no grade 3 mucositis. We usually see mucositis with TBI-containing regimens. No grade 4 toxicities, no treatment-related mortalities. We were able to dose escalate beyond standard 12-gray TBI doses. We defined a 16-gray MTD on this particular trial. And of note, the first patient ever treated with this type of approach is still doing well. She had stage 1 myeloma. 9 years later, she's still doing well. We went on to do a phase 2 trial that has not been published, but presented in abstract form. 28 patients at 16 gray, mostly stage 3 again. Relatively short follow-up. You can see the CR rate's 39%, VGPR rate 21%. And again, short follow-up, but encouraging progression-free survival at 70%. So let me move on to the next category, which is TMLI plus a reduced intensity chemotherapy regimen. The rationale for this trial was this. Older patients, again, have no access to standard myeloablative regimens. What looks promising are reduced intensity chemotherapy regimens, such as fludarabine and Melphalan. But patients with very advanced disease do poorly with reduced intensity regimens. Groups such as those at MD Anderson attempted to combine TBI with reduced intensity regimens. They attempted to combine 9-gray TBI, but that was challenging because of the mucositis. So we felt we should evaluate the combination of TMLI as a form of reduced intensity TBI along with reduced intensity chemotherapy in an older population. These were patients older than age 50 or with comorbidities that would not allow them to go on to standard myeloablative regimens or TBI regimens. They had to be in remission with high risk of recurrence or with responding disease. This is the conditioning regimen. This was not a dose escalation trial. We kept the TMLI dose at 12 gray. Again, BID fractionations, and throughout our experience so far, it's been BID fractionations at around 1.5 to 2 gray. And you can see there fludarabine and Melphalan. This has been published in Blood, as you can see here recently. 33 patients, mostly AML, most of them very high risk. Induction failures, for example, first relapse, second remission. When you combine chemotherapy with TMI, there are more side effects. The most common was stomatitis in 3/4 of patients. That's NCI grade 3 stomatitis. Also, nausea and diarrhea was seen. Relatively short follow-up in the publication, but the overall survival at 2 years is 46%. What was also important to us was the non-relapse mortality rate, 19% at 1 year, 25% at 2 years. If you look at the fludarabine Melphalan literature, this is comparable to chemotherapy alone. So we felt that this particular protocol, we could demonstrate the feasibility of combining 12-gray TMLI with fludarabine and Melphalan in an older population. The oldest person that we have treated with this regimen, the oldest in that protocol was 68, but we've treated a 70-year-old successfully. And again, the acute toxicities appear to be no greater than Flu-Mel alone. And then finally, let me describe to you our most recent effort combining more standard intensity chemotherapy regimen with TMLI, and we are escalating on that. And that is also in a poster here at ASTRO at, I believe, 3194, poster 3194. This is a phase 1 trial. We wanted to evaluate the feasibility, toxicities, and to define the MTD of TMLI when combined with Cytoxan and VP16. Again, very advanced patients, AML and ALL. These are patients who we could not get into remission and would not go on to any transplant trial here at our center or other centers. And this was a younger patient population. This is the study schema. We've gone through 8 dose levels from 12 to 19 gray, delivered over 10 fractions over 5 days. Of note, the dose-limiting toxicities are defined by grade 4 NCI or Bierman grade 3 criteria. That allows us to potentially escalate even higher than the previous phase 1 trial, combined with etoposide and Cytoxan. These are the latest results as of 2 weeks ago. You can see mostly AML on this study, all high-risk disease, mostly induction failure. If you can see in the second to the last row, most patients had blasts still within the marrow, median of 55% involved, some with 80 to 98% marrow involvement going through this trial, and a sizable number with extramedullary disease. These are the toxicities, Bierman grade toxicities, mostly grade 1 and 2. We had 1 episode of stomatitis grade 3, but only 1 at that dose level, so we continued to dose escalate. That dose level was 15 gray. As I told you, we're now at 19 gray. We had 1 patient each with lung and renal grade 3 toxicity felt secondary to infection rather than to the regimen. These are the median organ doses as we escalated on this trial. And I think what our physicists have developed is a treatment planning process that allows us to escalate to the target region without a commensurate increase in the organ doses, if you can see it from that graph. In addition, if you look at the lung D50 doses, they still are below that of what you would expect for standard TBI. 39 patients went into a remission, 39 of the 45. That in itself is encouraging to our transplanters. 30 unfortunately have relapsed, mostly in the marrow, but we've had 6 with extramedullary relapse only, and 1 with extramedullary relapse, as well as bone marrow relapse. But of those that have not relapsed, 12 remain in complete remission, and 11 are still in remission at a year to almost 5 years out. So that last bullet item keeps the entire group encouraged, and the fact that these results are encouraging in this population, we are very interested in looking at what it would do in a better prognostic group in subsequent trials. The non-relapse mortality, relatively low, in fact very low compared to published literature. Overall survival and progression-free survival, again, remain encouraging. One of the main concerns, even before we treated the first patient, was that we would not be delivering TBI, and therefore extramedullary relapse rates would be higher than in the TBI population. We continue to monitor this. We published 2 years ago in abstract form, 86 patients. This is the recent publication of 101 patients treated from 2006 to 2012. These were the first 101 patients treated at our institution. Median follow-up relatively short. 12.9% had extramedullary relapse, 9 of those without bone marrow relapse. The strongest predictor of EM relapse was whether they had EM disease at the time of transplant. We had a cumulative risk of EM relapse of about 11% at 2 years. We've had 19 relapse sites, and we looked at the dose that each of those sites received, and there did not appear to be a dose dependency in that they recurred whether they were in the full dose region, 10 gray region or higher, or even in the low dose region. And when you compare it to the TBI literature, the EM relapse so far on our efforts are comparable to that of standard TBI. So in summary, targeted TMI and TMLI is feasible. It's not only feasible at City of Hope, but it's feasible at other centers. And we are really excited and encouraged to see centers in the US, in Asia, and in Germany, in Europe joining in. We have seen a reduction in organ doses of 15 to 50% of the prescribed target dose. That's the median organ dose or D50 dose. The acute toxicity profile, we feel, and I hope you also feel, is acceptable and consistent with the organ dose reduction. 16-grade TMI without concurrent chemotherapy in a myeloma population with NCI grade 3 toxicity being the stopping criteria is feasible. TMI with 12-grade Melphalan and fludarabine is feasible in an older population, so it again broadens the spectrum of patients that could undergo a radiation-containing regimen. TMLI, we feel, can be escalated to 19-gray with full-dose Cytoxan VP16 in very advanced patients with very few other transplant options, if any. So we're, again, encouraged. In our plans, we are currently at a 20-gray dose level, finishing a initial cohort of 6, and we'll likely move to a phase 2 study at the 20-gray level. And finally, now that the effort is at other centers, we are hopeful that eventually we can move on to multi-center studies. So I'd like to thank you for your attention.